Hi everyone, thanks for listening to my presentations. Today I will be talking about hyponatremia treatment. And this should form part 3 of my presentation as per hyponatremia. Part 1 was all about causes, signs and symptoms of hyponatremia. Part 2 was all about the diagnosis of hyponatremia. Today I'll be rounding it up with the treatment. Okay, let's go. Warning: don't overcorrect too rapidly. To prevent Central Pontine Myelinolysis or Osmotic Demyelination. I'll go into that later on. But don't overcorrect too rapidly. Before we dive into treatment proper, we need to brush over how we got here. Here, we are dealing with more water than sodium. And this is caused by either increased water intake or decreased water excretion, either because the kidney is failing or has even failed. And also because the brain is continuously releasing ADH. And the ADH works on the kidney and blood vessels to retain water and decrease urine volume. The ADH will do that by binding to a receptor on the collecting ducts of the kidney and subsequently promoting the reabsorption of water back into the circulatory system. We need to answer some basic questions before making selection as per what to do in the face of hyponatremia. And the questions are, how long is this hyponatremia? Because some people, when they have become chronic, now the system will have a way of handling it and the stress is less. How severe is this hyponatremia? Because we would not be rushing when the value is just 130 milliequivalent per liter compared to 120 or 115 milliequivalent per liter. What symptoms are we dealing with? How severe are the symptoms? Any recent trauma like brain injury, any recent brain surgery or not, or surgery in other parts of the body? We need to answer those questions. Still on some basic questions, any recent hemorrhage, so hypovolemic, hyponatremia, so we'll look for blood transfusion right. Ascites, maybe liver cirrhosis is here, pleural effusion somewhere, edema, we're dealing with heart failure, because if we don't tackle the root cause, we will not win the battle, okay? And of course, are we having brain tumor somewhere? We need to answer all those questions. In all cases, we must identify the underlying causal causes and treat that. Without that fundamental, pattern of treatment, we are not going to get a cure, okay? We have to discontinue any ongoing medications that can cause decreased sodium level. Let me repeat. Sometimes we are not dealing with hypovolemia. It is only hyponatremia and nothing else is wrong, just simply because this man or this woman is on certain medications that could shut down the level of sodium from ECR. For example, Carbamazepine. This is the mood stabilizer or anticonvulsant or for pain or for whatever reason you are using it for, but it's shutting down the sodium. Knowing that carbamazepine could do that, that is the end of the problem. Decreased fluid intake, of course, already we have more water than sodium. So We don't want additional water in this patient, although it is very difficult to cope with. Let me face facts. I've had cases where nurses and patients will be fighting over whether or not to drink more water or to just keep the water away. The patient will want to drink as much as they feel like. And the nurses will be saying, no, the doctor said you can't have more than this volume within 24 hours. That has caused a lot of trouble. I don't blame the nurses. I don't blame the patient. It's a difficult thing. And increased dietary salt. I'll go into details of that later on. And of course, we have to discontinue hypotonic saline or IV fluids. Okay, now there's a problem. In the case of acute hyponatremia, it means the problem is less than 48 hours in duration. So this is serious. We have to admit into the hospital. And we need to determine, is this a mild or severe case based on the presentation? In severe cases, that will warrant the use of IV lines with 3% saline, and we can repeat 3% saline as needed. But we have to keep an eye on the level of the electrolytes, particularly serum sodium, and we can assay that every 1 hour. When we start the treatment, right? Every 1 hour, we'll assay for the electrolytes, particularly serum sodium. But when serum sodium has increased by between 4 to 6 milliequivalent per liter in the last 24 hours, then we change to monitoring every 2 hours. And we can even extend the hours of monitoring when the value keeps increasing. In other words, the frequency of monitoring will decrease as the value of sodium increases, but not too rapidly corrected, please. No. Okay, if this is a mild or moderate situation, then we need to ask, is there water diuresis and sodium is corrected? Then we check the serum level of sodium every hour until we achieve 4 to 6 milliequivalent per liter rise in value of sodium. If sodium drops further or is not rising, then we'll give 3% saline as 50 ml bolus. If there is no self-correction, like we found on the previous slide, which means there is no water diuresis and there is no rise in sodium in the serum, then something will change. Let me explain. What I meant by self-correction is that the individual is peeing more, losing more water, but not losing sodium. So urine osmolality and urine sodium is not high because sodium is not lost in urine, but water is lost. So more sodium is being reabsorbed into the system, making the serum sodium to be rising. Okay, that is self-correction. So if that is not the case, then we will go directly to giving 3% saline at 50 ml to block further drop in the value of sodium. Okay, then we will start monitoring the sodium level every 1 hour. Why that? We want to determine whether we need more fluid or not, whether we need more 3% saline or not. That's why we keep monitoring. And when we are reaching a rising value between 4 and 6 milliequivalent per liter, then we will not be worrying ourselves to give more 3% saline. If this is SIADH or chronic hyponatremia, then we will do something different. We will add loop diuretics. For example, furosemide, the trade name is lysis, right? Could be added to the treatment. And of course, oral salt supplementation or salt tablets could be used. Some will go for urea. But we need to watch out for the symptoms that we're dealing with. Severe symptoms here will include seizures, obtundation, coma, and respiratory arrest. If we have that, then we need to act fast. Okay, in chronic hyponatremia, that means the onset of symptoms is greater than 48 hours. If there are severe symptoms, then we should manage as if we are dealing with acute hyponatremia. Okay, that will warrant hospital admission. Okay, chronic hyponatremia but no severe symptom or symptoms. Then we have the time to check the serum sodium level. If it is less than 120 milliequivalent per liter, then we could take the history. And of course, if we find out that this is self-induced, for example, this is psychosis polydipsia, then we'll be monitoring the sodium level every 6 to 12 hours after counseling against excessive fluid intake. If this is not self-induced, then we'll need to look out for ascites somewhere, pointing to liver cirrhosis, any edema or effusion, trying to rule out heart failure. Okay, then we can give 15 to 30 mils of 3% saline IV push, okay, with 40 milligram lysis intravenously, that is furosemide. If sodium level in the serum is checked every 2 to 4 hours, and we find out that it's increasing by between 4 to 6 milliequivalent per liter in 24 hours, then we don't need to rapidly increase the level of sodium any longer. At this juncture, we have to adjust the level of lysis, okay? So we will stop both lysis and 3% saline when we reach the value of serum sodium between 125 milliequivalent per liter and above. Okay, let me repeat. We will check the serum sodium level every 2 to 4 hours. If it is increasing by between 4 to 6 milliequivalent per liter in 24 hours, that's fine. We don't need to rapidly increase sodium level. At that level, we'll then adjust the level of the lysis. We will stop both lysis and 3% saline when 125 milliequivalent per liter level of sodium in the serum is reached. Still on treatment, we have to check for organ failure, like liver, in the face of liver cirrhosis, heart failure, or renal failure. We have to find out about reversible causes like hypovolemic state, nausea, vomiting, diarrhea, bleeding, adrenal insufficiency, transient syndrome of inappropriate antidiuretic hormone, surgery, pain, or drug. Then we have to give 3% saline at just 15 to 30 mils per hour with desmopressin at 1 to 2 microgram intravenously or subcutaneously every 6 to 8 hours. Okay, we have to monitor sodium in serum every 2 to 4 hours and adjust saline rates to gain 4 to 6 milliequivalent per liter in 24 hours. Don't rapidly correct, please. Once 125 milliequivalent per liter level of sodium is reached, then we stop the infusion. Osmotic demyelination. When hyponatremia is rapidly corrected, then we stand the risk of running into Osmotic Demyelination Syndrome, otherwise known as Central Pontine Myelinolysis in the past. Here, the pons will be spared, and the symptoms will start at 6 days after the treatment. It may be irreversible, but you can try to salvage the situation by gradually relowering of the serum sodium that is now high. In some patients, there will be high probability of running into osmotic demyelination syndrome when they have hyponatremia, and we are trying to correct that. Such will include malnourished patients. So if we find hyponatremia in a malnourished patient, we should be careful because they may likely get osmotic demyelination syndrome if we act too fast. In fact, in them, we don't have to act too fast before we run into trouble. Also, in concurrent decreased potassium, remember, from the onset, we will assay for the value of all the electrolytes, right, including potassium. If the sodium is down and potassium is also down at the same time, if we rapidly correct the sodium, then osmotic demyelination syndrome will be at the door. If the serum sodium level is below 105 milliequivalent per liter, then the correction should be very, very slow also. Because if we correct this very rapidly, then osmotic demyelination syndrome will surface. In alcoholic patients, for example, beer potomania, they stand the risk of osmotic demyelination syndrome more than the rest populace. With the above, we then treat with 3% saline and desmopressin. Finally, we will examine and determine whether we have decreased probability of osmotic demyelination syndrome. If that is the case, which means we have decreased probability of osmotic demyelination syndrome, then that's fine. We'll give just 15 to 30 minutes of 3% saline. No desmopressin. Take that off. Then we'll continue to monitor sodium serum level every 2 to 4 hours. We will adjust the saline infusion rate to gain 4 to 6 milliequivalent per liter of sodium within 24 hours. And we'll finally stop the treatment once we have reached 125 milliequivalent per liter of serum sodium level. And with that, I've come to the end of this presentation. Remember to share. Remember to subscribe. I appreciate it. The next presentation will be all about hyponatremia. Thank you.